What's up, everybody? Floating Vent Guy is back with another episode of the Peak Inspiratory podcast with your host, Nick Palm Crit, aka Palm Toilet, aka that should be enough. So, have been talking a lot about in the past few days the time constant, sort of like bringing this topic back up. I thought that I would go through a case because I feel like it's hard to talk about in of itself. So, I feel like a case would be good to sort of bring home the physiology. So, this was a real case. This was my first day as an attending, I believe. So had some interesting points to learn. So this is supposed to say patient, although I guess we can call her Patty. 68-year-old female, all this past medical history, came in essentially with shortness of breath, got the asthma COPD cocktail, including IM epi, also started on BiPAP in the emergency department, got a little bit better, so she was able to go to like a step down floor. She was on BiPAP overnight for for her comfort, and in the morning she had more respiratory distress and was breathing pretty hard, and a rapid response was called. And once the rapid response was called, the patient was brought to the ICU because of how the patient looked. So during the rapid response, someone obtained an ABG, which you can probably guess how I feel about that. Not that it sort of overly matters, but it's not going to really change, ultimately what happened because the patient looked terrible and was on BiPAP and was failing. If I remember correctly, it was very tachypnic into like the 30s. Her volumes were pretty low, like the 200s. So she's air trapping. Obviously, she can't breathe. She's getting more and more obtunded. Her PaCO2 had risen to like 92, although I think she had some baseline hypercapnia because she did have COPD as well. She was unresponsive and obtunded, therefore we intubated her. Intubation went smoothly, and post-intubation, she's still paralyzed, right? Now, you guys have heard me talk a lot about obtaining the time constant. And with the Servo U, you have this screen here, which when you take these static measurements, it essentially spits out the time constant because it multiplies the resistance and the compliance, which is one way you could obtain the time constant, and it gives you a number. Now, not that like I'm some savant at this, but I think I've been sort of like doing this long enough that I can kind of tell when the time constant kind of comports with what I'm seeing on the waveform. So I believed it. But if you don't believe it, we'll talk about another way that you can sort of double check, or if you don't think the ventilator is giving you accurate numbers or something of that sort. But this was the number that I got. So remember that when we start the initial sort of total volume settings, I do agree with that, we should be starting somewhere between like 10 to 14 with a volume around like 7 ml ish per kg. Most of the patients with asthma, while they're incredibly hypercapnic, that's because they're obstructed. So once you give them adequate expiratory time, you decrease that dead space, and even though your minute ventilation, maybe pre-intubation was some number, 6, 7, 8, whatever it is, it's not effective, right? Because they're not having effective alveolar ventilation. But once you give them enough expiratory time, you allow a minute ventilation that's a lot more effective. So most of the times, once you intubate these patients and you take the auto-PEEP out of the equation, they're much better. So, this was the first sort of numbers that I got. She had some auto-PEEP. We played around with her settings and her volume. I stick to this lower rate, higher volume strategy because most of these patients have normal compliance. So even if you give them a 7, 8, 9 ml per kg breath, their plateau pressure is not going to really be that high, number one. Number two is that in these situations, your, volume trauma is sort of like repetitive, large total volumes. If you give the lung a large total volume, within the plateau pressure goal, even if you do that for a few hours, right? Is that really going to cause damage? I don't know if like a few hours matters, but remember we're just parking them there for now until we get more information, and then we'll bring the rate down more and maybe the volume down if we need to, and then sort of base our numbers around the time constant. So, our post-intubation gas like really wasn't that bad. I mean, 73160, this was a VBG. So, playing around with the numbers. So, what are we doing exactly here? So what we're doing is we're getting the time constant, which here is about 1.2. And let's just say for argument's sake, we say it's 1 because the math is easy. And remember, I can't do math because I'm kind of dumb at math. But if you obtain the time constant, however you do, whether it's the resistance times compliance or depending on what ventilator you have, if you get an a expiratory time constant like with the Hamiltons, or there's a few other ways. I won't go over the third one because it gets a little confusing. I don't want to make this more confusing than it already is. But if you are somehow able to get a screen grab of your ventilator screen, which the Servo U, sort of like off the screen here, there's a recorder and like a camera. If you press the record button, it'll take a 30-second recording before and after that point. Then if you go into the files, you can sort of drop a green line down here, and then what it'll give you is it'll give you the volume, and then it'll give you a timestamp. Because remember, all of these curves are against time. Time is in the x-axis. So if you take, let's see, we turn on the pen here. Oh boy. So if you take, let's just say the total volume you set. So this is set at 580, right? I went up on the volume a bit. Her plateau pressure was good. We were ventilating her. She didn't have any auto-PEEP. Things were beautiful. And as you can tell, right, like sort of here, her peak expiratory flow isn't that great. It sort of really kind of cuts back, and then she hits sort of like all this resistance, and it just takes a really long time for her to get air out. And she still doesn't get it out even before the next breath. If you obtain the time point at some number, let's say 580, which is the total volume, or 550, something maybe that's round, whatever, and you get the time point that it correlates to, and then you remember you have to do 37% of that, meaning 63% has been dissipated, but 37% of whatever volume you choose. If you want to choose a round number, go for it. You want to choose 580 because it's like sort of the most volume, go for it. Remember, the volume doesn't matter because it's a rate of decay of any volume. Okay, it's a rate of decay. So just to make the math easy, we chose 500, let's say, or 580, whatever you want. You get 37% of that. So we have to find the first time point, which is the initial volume we're talking about, 580, 500. Then you get 37% of that. And then let's say that's over here, right? And then you get the other time point. If you subtract these two time points, so let's say this is 0.5 seconds and this is 1.5 seconds, then subtracting them gives you 1 second. One time constant is 1 second. Now remember, we need 3 of them to not auto-PEEP or to avoid auto-PEEP. So that means our total time in exhalation needs to be 3 seconds. 3 seconds. If we make our inspiratory time, which it's not 1 second here, but if we made it 1 second just because the math is easy, that means that our total breath-to-breath time, our time in inspiration, and all of our time in expiration needs to be 4 seconds. 60 divided by 4 equals 15 breaths per minute or under in order to avoid auto-PEEP. Now, you're handcuffed by the total volume in a lot of ways because obviously we can't give like a rate of 4 and like a 2-liter total volume. That doesn't really make a ton of sense. But I think a lot of times we can get away with total volumes that are 7, 8, 9 ml per kg as we watch our plateau pressure. Because remember, if we recall, total volume sort of as an absolute number isn't in the equation of natural decay. And remember, the equation of natural decay is really just this kind of talking about the volume time curve, right? So how fast does volume decay here? So we say one time constant is how long it takes for 63% of the volume, 37% left over. 2 time constants, 85% of the volume, 15% left over. 3 time constants, 95% of the volume, or 5% left over. If you get at least 3 time constants out of exhalation, you will avoid auto-PEEP, okay? So you can either do this method and sort of eyeball it, which I probably did, to be honest with you, because, 1 time constant of 1.2 is pretty long. Normal, I think, is about 0.5 to 0.7, so she's almost double the amount of time. So, I'm expecting rates to be in the low teens, and when I do the math, like it's sort of there. But if you want to be absolutely sure, you can do the math. It's not hard. It just depends on how you get it. So you can either trust what the machine gives you if, number 1, the patient is passive, number 2, you're getting a good hold. Another way you can do it is if you can manipulate the screen to get the timestamps and then do your math. That's another way you can get it. We talked about this before, Melody and I, but I think it's a powerful number to have because if the patient's paralyzed, let's say, maybe for a day or so as you're getting them better with your steroids and your nebulizers and whatever else, you can check the time constant. The time constant's now 0.6 and yesterday was 1.2. Guess what? The patient's much better. You'll be able to tell that other ways because your waveforms will look better. You'll notice that it gets to the baseline faster. Your peak area pressure might get better because you don't need as much pressure to generate flow, that kind of stuff. So with this case, overnight, she was put on PRVC because her peak area pressures were high. I think we know by now why that would be a issue. Nevertheless, I came in and now she's not paralyzed anymore and her total volume is sort of all over the place. So someone, someone overnight sort of dropped the volume because while my volumes were a little bit higher, I wasn't getting high plateau pressures, but someone was nervous about the volume. So we dropped it closer to like a 6 ml per kg strategy. Obviously, since the patient's not paralyzed, or maybe not obviously, since the patient's not paralyzed and you're on PRVC, and since PRVC is a pressure-based mode, you can have more flow being delivered depending on if the patient's interacting. The problem with this is, classically, when you think about obstructive lung disease, if you have a patient on volume control and they're auto-PEEPing, the peak area pressure will just get higher and higher and higher. Depending on what your alarm is, it might alert you before it gets too high. If you make the alarm 50 and if your peak area pressure is about 35, if you start to generate more and more auto-PEEP, at some point it's going to alarm and then it's going to alert someone, number one. Number two is if you use pressure control, same thing with the alarms, but this time you have to set sort of like a minute ventilation alarm because as you get more and more auto-PEEP, you won't generate the same amount of volume for the same amount of pressure because you're starting from a higher baseline PEEP, right? If your inspiratory pressure is 15 and you're starting from 5, then you have a delta of 15. So that generates some volume. If you have now 5 of auto-PEEP on top of your 5 of set, now your delta is only 10. So your volume will suffer as a result. When your volume suffers, your minute ventilation will suffer. When your minute ventilation suffers, the patient will get more acidotic. And then if they're breathing, they might try to sort of speed up their breathing. And then that'll just repeat the cycle over and over again. The volumes get smaller and smaller. And eventually the patient will either have hemodynamic collapse or pneumothorax from the auto-PEEP or can get sort of life-threatening acidosis. What I think PRVC does is, unfortunately, it gives you sort of both, which is if you see these pressures, they're sort of up and down. So, she's taking volumes that are sometimes bigger than 350 and then sometimes smaller than 350. So what the machine is doing, constantly adjusting the pressure, right? Which is causing an issue because number one, it may or may not ring for high peak area pressures. This wasn't because someone made the peak area pressure alarm super high, like 70 or something, right? And there's a lot of bad stuff that can happen between 30 and 70. So you need to think about what your alarms are set at. And that's usually an RT thing, but all the clinicians and everyone at the bedside should sort of have these things in mind. The other thing is that what, unfortunately, it's supposed to be a video, it's not showing through, but I think the point is well taken, is that, if you see here, this flow starts to sort of go up towards the baseline, but doesn't really have enough mustard to trigger the ventilator. This is an ineffective trigger, right? The patient tried to trigger the vent. They couldn't trigger the ventilator. So by definition, it's an ineffective trigger. So what you should be thinking about is, does the patient have auto-PEEP? Now, I knew that she had auto-PEEP because I knew her numbers before. So when someone increased the rate or when someone dropped the volume from, and unparalyzed her, they allowed her to breathe more, and then switching her to PRVC allowed her to take bigger volumes. So I knew she was going to have auto-PEEP, which she wound up having. So now when I re-paralyzed her, I recalculated the time constant, and I redid the math, and now her rate was supposed to be 8. But then throughout the night, again, so I re-paralyzed her. She needed a rate of 8, which we left the volume a little bit lower, but she was paralyzed at this point, so couldn't really couldn't interact with the ventilator. So with a rate of 8 and a volume closer to 350, we were getting acceptable minute ventilation. When I left sort of that day, her peak area pressures I noticed were like in the 20s, which was beautiful. But when I came back the next day, I noticed that her peak area pressures were much higher. They were 41. And then someone had increased the respiratory rate to 14. And then all night, apparently the patient was sort of ringing for high peak area pressures. So they increased the peak area pressure alarm to 50 instead of just investigating why the peak area pressure might be high. So again, when I recalculated the time constant, we needed a lower rate, still of around 8. She had more auto-PEEP. Her acidosis was a bit worse, so I had to go up on the total volume. So now we were stuck on a rate of 7 and a total volume of 500, and her plateau pressures were pretty good. Now, there's a lot of like ringing in the circuit, which I think is from the continuous albuterol she's on. But the one thing I want you to notice here is that this starts to dip down below the baseline. So this is a result of dynamic hyperinflation. So as the auto-PEEP builds, the ventilator will sort of reset the baseline once it gets to sort of a steady state. But as you alleviate that volume, the ventilator, there's going to be more volume out than the vent put in, so it has to go sort of below the baseline. So it's getting more out than it expects, so it goes below the baseline, which is a result of the dynamic hyperinflation. But because this rate was incredibly low, not everyone was overly comfortable with it. So as I left for that day, they wanted to switch back to a rate of 13 and a total volume of 350 for about the same minute ventilation. This video doesn't play, unfortunately, but if it did play, what you would see is that on a rate of 13 with a volume of 350, her auto-PEEP was 24. Now, we could have probably expected that because like the rate that we calculated was needed to be 8, right? And remember, the total amount of volume is irrelevant. It has to do with the rate. So it shouldn't surprise anyone that her auto-PEEP is going to be much worse if we violate the goal of her rate, which we did. So then we switched back to a rate of 8 and a total volume of 500, and everything was better. The patient was eventually extubated. So what I want to leave you guys with is that I personally think ACVC is the best strategy to go with in severe asthma and severe obstruction, because as the auto-PEEP builds, your peak area pressure will get higher and higher. And then at some point, as long as you don't make the alarm super high, the vent will alarm and it should get someone's attention. And then someone should look at that and say, wow, the peak area pressures are much worse. I wonder what that's from. That could be from auto-PEEP. It could be from whatever. If you're going to use a pressure mode, I think you need to be really cognizant of the alarms, because if you make the minute ventilation alarm too low and the patient has auto-PEEP, you'll never ring for a peak area pressure alarm, right? Because we set the peak area pressure in pressure control. I really think you should avoid PRVC in this situation, especially with a spontaneously breathing patient, because the patient does something, the vent does something. The patient does something, the vent does something. There's too many unknowns. Remember, the peak area pressures in severe asthma, they're high because it's taking a lot of force to get air through the airways. That's not necessarily meaning that that amount of pressure is reaching the lungs. What we're monitoring is the plateau pressure, and we still want our plateau go less than 30, number one. Number two is that, remember, we're aiming for no to minimal auto-PEEP. Do we have to sometimes concede a little bit of auto-PEEP because we can't sort of get the rate down enough or the volume high enough to dissipate the acidosis, or if the patient develops sepsis or some other infection or some other metabolic acidosis? Sometimes we need to accept some auto-PEEP, but you know, that should be making you think, do we need a rescue strategy? Like, do we need to be calling for ECMO maybe? So just keep that in mind. Your expiratory time is a result of your resistance and compliance. Your total amount of total volume isn't really represented in the equation, therefore it doesn't matter that much. Is there some volume that's just too high? I'm sure there is, but if you're sticking to 7, 8, 9, even 10 ml per kg, as long as your other markers of safety are good, then I feel like then I sort of tolerate that. Remember, all of these numbers only matter if the patient is passive or paralyzed. So you have to be sure that the patient is passive or paralyzed, because if they're not, then the numbers could be off. So this was a quick case. Hopefully it answered some questions about how to really use the time constant at the bedside. I think that a lot of the questions that RTs have or are uncomfortable with like really dropping the rate low are well-founded, and I think a lot of people share the same concern, but I think that's why it's really important to understand the time constant concept, so you know when we get into this situation we need to drop the rate because the patient has severe asthma, what the methodology is behind it. So hopefully this was helpful. Please like, share, subscribe, comment, thumbs up, thumbs down. We're learning and growing as we do this podcast, so hopefully it's helpful. Thanks.